Okay. Hello, guys.
Good afternoon, everyone. My name is Jocelyn Culpitt, and with me today is Dr. Amy Mao, who's our specialist consultant psychiatrist here with the Eating Disorder Service. Thank you very much for joining us today. We just wanted to see if we could perhaps take an opportunity to touch base on treatment in a GP practice with regards to eating disorder patients and what that might look like for you. But as we, before we start today, I'd obviously like to acknowledge the traditional custodians of the land on which we're meeting today, the Gubbi Gubbi people, and to pay respects to our local Indigenous leaders, elders, past, present, and emerging.
Okay. I thought we should probably talk a little bit about what our service is. This will be very quick, but it is basically a community-based but with in-reach service offering education, consultation, and treatment recommendation and outpatient psychotherapy. So it's a little bit different to a typical mental health community team in that we are solely focused on treating not only just eating disorders, but also providing therapy and providing consultation, so the specialist consultation for all kind of professionals working in the field of eating disorders in the local area. And as you can see on the screen, it's our email and our contacts up there. We're always very happy to correspond with people. I thought we'll get straight into it, but I might let Joss start off with that first.
So I suppose we'd like to start by talking about what are eating disorders. And we have an analogy we like to use. And if we think about the person who is affected by an eating disorder as being someone who is amongst some stormy seas and they're floundering around and they grab the only thing available to them, and it's a life jacket. But the life jacket is an eating disorder and they're clinging to it. And as clinicians, we paddle up in the boat and we help scoop them out into the boat with their life jacket on. And we're paddling along with them, trying to support them. But if the seas are really, really big and stormy still, we might need to call on some other clinicians and family and support persons in their boats. And hopefully being surrounded by everyone, it will become more stable until we can help the person onto dry land where they'll feel safe enough to take the life jacket off and start to do things in a different way.
Okay. So that is the overarching theme of how we look at eating disorders, but I thought we need to get down to specifics of eating disorders. The slides are going to be available, so I won't go into the details, but I just would like to point out the differences between each of the different eating disorder diagnoses. The way I tend to think about eating disorders is that over a person's lifetime, they can actually have many different patterns of an eating disorder. And that, you know, from what might be anorexia nervosa at the start may then turn into binge eating disorder or bulimia nervosa. So it's very important when you're kind of looking at the diagnosis or looking at the kind of the patterns of symptoms to try and match what's best with what the patient is describing. So anorexia nervosa is about restricting the energy intake, and it's about the inability to restore that kind of weight or nutrition despite kind of knowledge of the concerns that it's causing their family or yourselves as their medical professionals. And there's a very kind of strong emphasis from the person's part on that weight and shape is essentially more important than anything else, maybe even more important than the medical complications of the eating disorder. Then there's bulimia nervosa. So I would like to point out often when the patient describes that they have a binging or a purging, so vomiting or laxatives or exercise pattern of dealing with their eating, it doesn't mean that they automatically have the diagnosis of bulimia nervosa. So actually, from my perspective, when you think about bulimia nervosa, it is you'd have to make sure that their predominant pattern is the binge and the purge, and not that they're restricting outside the binging and the purging. If we then go on to binge eating disorder. So binge eating disorder is probably in a slightly different kind of a way that we think about eating disorders once again. It's actually probably the most hidden eating disorder that we know of. The predominant theme of a binge eating disorder is someone who binges, but they don't compensate by, say, vomiting or laxative use or over-exercising. And often they may or may not have kind of strong weight and shape concerns, but they definitely will have a strong sense of loss of control during the binge episode, as it were. Then this probably is what we used to be known as EDNOS. These days it's called Other Specified Feeding and Eating Disorders, or OSFED for short. So when a person, when I see someone with an eating disorder that they may not strictly meet the criteria for any of the other diagnoses, then, but they still very obviously have an eating disorder, then that's what I would normally think about as the working diagnosis. So we've listed some examples up there from the DSM-5. So if you want more details on all of these disorders, it's actually in DSM-5, there's much more kind of in-depth criteria, as a word, I think. So if you look at some of the examples, say typical anorexia nervosa, so weight within or above the normal range, that'll be quite important later. Things like purging disorder, where they might only purge and don't really engage in kind of binge eating. Then there's night eating, where people might wake up in the middle of the night and kind of repeatedly eat. Then if we go into our last kind of eating disorder to be aware of. So this one is a relatively probably newer understanding for a lot of people in the eating disorder field, and is meant to be more commonly diagnosed in young people. So avoidant and restrictive food intake disorder, or ARFID for short, where people with this particular diagnosis often don't have as much weight and shape concerns. So it's more about either the sensory component or the aversive consequences they've had with particular food items, or the experience of eating, and then that then leads to a restriction of their intake and significant weight loss and significant kind of medical risk. So it's still equally as risky medically as any of the other eating disorders, but it's just often kind of a slightly different way that it may present to people. So now that we talked about all the different diagnoses of the eating disorder, I thought we should go into what causes an eating disorder. So, Joss?
Yeah, so I suppose the big thing about the causes of an eating disorder, to understand that in fact there is no one cause. They're really complex, and there's usually multiple contributing factors as to what will end up eventually becoming an eating disorder. As you can see, we've got a very recent understanding of the genetic vulnerability of people, and that's becoming more and more researched, and you will see in our next slide where we can reference that. Dieting still remains one of the most significant causes, though, and so when we unfortunately live in our current society of very diet cultured, diet focused, it can lend itself for these people. So if people have some vulnerabilities, some of the other things that may be sitting there, if they go on a diet, as you can see, they're far more likely to end up developing an eating disorder. The personality traits are very interesting. You will see that there are lots of different options on there, and we find that for most of the people we see, that they would have quite a few of these as part of their personality structure. So it's very important, because it helps us understand perhaps why they can also have difficulty letting go or taking the life jacket off.
So coming back to that kind of metaphor, I would like people to think about the eating disorder diagnosis as the literal term life jacket, and then the different diagnoses underneath that. So whether anorexia nervosa or bulimia nervosa as the different styles of life jackets that people can have, and then these kind of causes of eating disorders as the kind of making the materials that may have made up the life jacket to make it a life jacket to begin with. We won't belabor the point, but there is also kind of significant time periods in a person's life that is quite important. So we've listed that under the life stages, where it will be important to kind of be aware that if this person has already struggled with disorder eating or has had an eating disorder before, that these are risk periods, and certain questions should be asked. We also put diabetes, type 1 diabetes. That is definitely something that we are coming, that's coming very common. It's coming across a lot more frequently to us as well. We will talk a little bit about that in one of our later slides. Now, I just want to quickly flash up the article associated with the genetics of an eating disorder. So the implication is that there is 8 loci within the genome that has associations with anorexia nervosa, and one particular area, if you go into the study, that it has to do with the metabolism. So the reason we are so insistent about talking about genetics is that it is not, an eating disorder is never a choice. It is always something that is multifactorial and quite complex in many ways as to how they then become the kind of disorder it is. Now, in kind of going into the comorbidities with eating disorders, so let me kind of turn that around a little bit. So within my own kind of psychiatric practice, I've seen, as you can see, a whole list of mental health conditions. I've kind of left there's obviously a lot more than that, but each of these diagnoses, I can tell you I have seen someone with an eating disorder. Often it's also a combination. So just because they have one diagnosis that might be the predominant kind of struggle that they may have to deal with, or the predominant kind of diagnosis that they have had, doesn't mean that they're not likely to have an eating disorder, kind of coinciding with that. There's also the physical health conditions that we've come across with people with eating disorders. So as we've said before, type 1 diabetes, people who often have kind of gastro concerns, chronic medical illnesses in lots of people, and this is probably one of my soapbox moments with the kind of people in terms of age. So older people, there's this kind of, I guess, kind of preconception that they are generally just going to have a lesser appetite, or they're going to be kind of, they will lose weight, and that's kind of quite a normal part of aging process. Well, we're here to say that please consider the possibility of either a relapse of an eating disorder or a start of an eating disorder in that range as well, and then cancer, obesity. So it goes back to the kind of the causes of eating disorder, where they may have all those factors, but there's a perfect storm of circumstances so that those factors all get activated, and then the eating disorder then takes over and doesn't let go. Going into probably stats, just because I like to kind of put that into context for things. This is based on the 2012, so it's a little bit out of date, but it's the 2012 Butterfly Foundation Paying the Way kind of report done by Deloitte Economics. So basically there's at that stage over 1 million Australians living with an eating disorder, but then less than 25% of people with an eating disorder actually access specialist treatment. So if you think about it, there's not many other illnesses that has that kind of profile. Eating disorder is the 3rd leading cause of disability due to a mental disorder after anxiety and depression. So it's actually quite common. And it's definitely the 3rd most common chronic illness after obesity and asthma, but it's not something we commonly think about. So one of the things that we always, the reason why we're always so insistent about kind of being aware of an eating disorder and being able to screen and being able to identify an eating disorder is that if the best treatment for the person isn't received within 2 to 3 years, and arguably in our experience, probably less than 2 is best, it's very likely that then it will, you know, because then you start changing the neural pathways and you start kind of changing the cognition so that then it becomes a chronic illness that an episode of, say, anorexia nervosa lasts an average of 7 to 10 years. That's a long time to have an episode of an illness. Now, eating disorders cost Australia $69.7 billion a year just in kind of lost work, lost health costs, etc., carer costs. Just for comparison though, depression only costs Australia 40, according to this report. So that's a big difference. There's a definite 10 to 20 year reduction in the overall life expectancy with someone with an eating disorder diagnosis. And definitely anorexia has, you know, one of the highest mortality of all mental health diagnoses. Arguably, probably opiate use is the only other one I can think of that there's kind of evidence suggesting that it's also equally as high. So now that I've told you all the kind of very scary, you know, the statistics and the kind of the concerns as to what we have about eating disorders, there's some basic things that would be very helpful to start off with, and I think particularly useful in a GP practice. So the SCOFF questionnaire, it's something that we recommend just putting, making it available in, say, the waiting rooms or in the consulting rooms. And it's just a series of 5 questions that you can consider or you can ask the person that may then indicate a need to kind of do further investigations or perhaps kind of referrals about whether there's an eating disorder or not. I think we have provided copies of that before.
Yeah. So if anybody would like a copy, it is done in an A4 size and is available. So if someone would like it for their practice, please just don't hesitate to email us and we can get one straight to you.
And then after, so again, this is, I apologize, this is an incredibly busy slide. It's from, we've taken it from Dr. Lisa Miller, from the head of the Western Australian Eating Disorder Outreach Service. Yes, hopefully I've got the acronym right. And these are the kind of signs of someone with a potential eating disorder. So there's, I know it's very kind of, there's lots of kind of information on there, and it's a great slide to print off afterwards for reference. But I thought there's a couple of things I just want to point out. So if we talk about, let me just have a, I can't point, can I, on this? No, I cannot point on this. So if we think about the brain and the heart, they're probably the 2 things. So on the right-hand side, on the central nervous system and the cardiovascular system, if the patient shows any of the signs in bold, which again, they're kind of sometimes, that does require a little bit of kind of detective work, then reasonably, if they also have eating issues, by the time they're showing these signs, I'd be very concerned about their kind of medical risk and what's going on, unless obviously there's another kind of condition that would explain that better. But usually in someone who's otherwise, you know, thought to be physically and kind of psychologically healthy, they really shouldn't have issues to do with, you know, pulsatile tachycardia. Their heart shouldn't be, they shouldn't be bradycardic. And they shouldn't be hypotensive. Yes, they might be short and skinny, but that doesn't mean that they actually should be hypotensive. They, you know, in terms of some of the other kind of concerns, there's also long-term concerns. So if you look on the left, there's definitely, and this is a question I always ask my kind of female patients with eating disorders, that if they haven't menstruated regularly for a year or more, then I would have significant concerns about their bone density if I know that they have an eating disorder. So there are just a couple of things you can kind of go back through at your own leisure, I guess. Now, the next bit is probably, I will hand over to Jocelyn.
Yeah, so we thought we'd perhaps talk about some of the signposts that someone may be when they're sitting with you in your practice and sitting there in the room with you, that these are some of the things that they may present with. And it could be that, of course, as always, they probably aren't necessarily able to actually tell you that they've got some concerns about their eating or their disordered eating, or that in fact they suspect they have an eating disorder. In our experience, that's not something they're often able to talk about, and they're often looking to us to perhaps sometimes interpret that for them. So some of those sort of warning signposts might be things like a rapid weight loss or frequent changes in weight, dizziness, always feeling tired and not sleeping well, and feeling cold most of the time, even in warm weather. So not uncommon for them to turn up and to see you and they've got a sweatshirt on and long pants and, you know, it's a really hot summer's day outside. Psychologically, some of the things that perhaps they might be able to tell you, but if not, some of the collateral you might get from family or friends or partners is that preoccupation with eating, their food, their body shape and their weight, where it seems to be taking over their lives, and people will talk about the fact that that's all they seem to be able to focus on. They often get very anxious and they feel a bit out of control. And they have quite a distorted body image, but that won't necessarily be one of the first things that you'll hear. That's often further on down the track when you've built trust. But it can be sitting there, and it could be something that someone else may tell you. Some of the behavioural warning signs, these are often something we see very quickly, which is that dieting behaviour that we talked about earlier. And a really big one that can happen very quickly is eating in private and avoiding meals with other people. So often you'll have people say, well, they used to eat with us out at the table and all of a sudden they're now cooking their own food, or they'll take their food, the dinner that's been made, and disappear off to their own room. So things like that are often a pretty big signpost that there's something going on.
And you know, and if you hear that there's often probably also normalization of some of the compensatory behaviors that we often hear. So it was quite shocking to me that sometimes I have kind of heard of cases where there's the kind of the understanding that, oh, it's okay, it's a phase they go through. They all, you know, all the girls go to the bathrooms after and vomit after their lunch. That's quite normal. This is just an you know, adolescent phase that people go through. Well, we're very insistent that it is definitely not a phase. By the time they're vomiting post meals, it is not a phase anymore. So what do you do then? If you think that someone has an eating disorder, how do you talk to them about that? Well,
yeah, it's not an easy one, and because of the nature of the illness, they're often very distrustful of people in general. And I suppose the big thing is for us to be able to let them know that we're not judging them, and that we're there to actually support them and support them on their journey and what that looks like for them. That we get that we can't fix it, that we can't do that, and that we'll work with them for it. So it's about being able to allow them time to be able to talk about it. Sometimes initially there may not be a chance to talk, but you might be able to provide some information leaflets that might be able to, that they could take away, that will sit more comfortably, and then perhaps next time they'll be able to talk to you in more detail about it. For a lot of people, they don't realise that there is treatment available, that it is accessible. Often people think that financially they can't afford to. I suppose we're now lucky and proof that there is a service available now where we're available and we are free of charge. So that, you know, that often can be of help to people because they just don't think that they can do it financially.
I think the other thing that we probably should think about is that if you, when you kind of talk to someone with an eating disorder, often their first instinct is to deny, to say that there's nothing wrong. And I think as GPs and as kind of practice nurses and as kind of people, the primary care professionals. Often it's about, you guys already often have the kind of the long relationship and the long kind of understanding of working with who this person is. So it may be that they may not want to talk about it, but they may still allow you to go through the medical kind of investigations and monitoring that is still quite important to determine what their risks are despite that. And in the other thing we thought it is important to point out that there is a difference in terms of how we think about things in child and youth versus adults. So there will be slides later on about child and youth, but I just want to say that it is incredibly important, particularly in child and youth, that if you even kind of have an inkling of suspicion, that you do act on that, because like we said before, if you can catch it within the first 2 years, you really can make such a difference in their kind of long-term trajectory versus 2 years versus 7 to 10 years. So I preempted myself a little bit with the previous talk. So the role of the GP and the practice nurse. So people with an eating disorder need regular monitoring. It's based on the Queensland Eating Disorder Service statewide guidelines. Again, this is a good reference slide. So it's just got the kind of the bloods, the physical obs, the ECG, the BGL, the weight, and the BMI. We have heard repeatedly that often the mental health or other kind of health professionals come and go, but GPs and the GP kind of practices and practice nurses are often the most constant person, the constant person in that person's life, the kind of someone with the eating disorder's life. So, even if they are not able to partake of the therapy or the other kind of treatment options, it's incredible what you guys can do for people with eating disorders to make sure that they actually survive until they're ready to make the changes. I thought we should quickly flash up good. I was a little bit worried about the technology just now. This is a table. Again, apologies for this being quite a busy slide, but it is available through Google. It's the Queensland Eating Disorder Service statewide guidelines. The table is basically a quick guide as to if the person has any of these concerns, then if they meet kind of these criteria, then it is time for them to come into hospital, because the risk would be too much to contain in the community. Often the other thing I actually kind of experience with people with eating disorders, by the time they've met these criteria, they're often so starved and so unwell from the eating disorder that they aren't actually able to make the changes necessary to make themselves medically safe again. Again, if you we can always, if you're not sure where to find that, we're happy to send you a link as to where you can access that. And I've just done a little bit of a lab testing cheat sheet. So when you've done all the bloods that you need to do for people with eating disorders, it's a little, like, in terms of interpretation, it's a little bit different to what we typically would kind of think about. So things that might be low or just out of the range for people who don't have eating disorder is actually quite indicative of what's happening for them and how severe it might be already for them. So by the time they have lab changes, by the time they have changes on their pathology, that usually means it's been going on for a little while now. And particularly we put potassium up there, as you can see, because obviously everybody gets really worried if the potassium is abnormal. But the mechanisms that people can engage in to deal with the eating disorder can be anywhere from purging to laxatives, diuretics that can still affect the potassium where they might otherwise, inverted commas, look normal, that there's nothing else going on. I won't belabor the point, but the other thing that I always like to look at is the bicarbonate. If their bicarbonate is high and there's no other medical conditions or concern that you're aware of with this person, often it's actually quite liberating to just ask them, look, I've seen your bloods. There's one of the particular electrolytes I'm concerned about that usually indicate that you're having to compensate for eating by vomiting. Is that something that you're having to do at the moment? Because it's quite a lot of people find it very embarrassing to talk about vomiting post meals, or find it kind of shameful to talk about it. So just being able to put it there on the table like that is very useful. And because it's you know, in black and white on a piece of paper, it's very hard to, you know, then it's easier to kind of talk about it, but it's also very hard to then deny that there's anything else going on, because it's, you know, it's quite evident there. We've kind of obliquely referred to this next kind of condition before, but I always think that it's really important to understand what starvation syndrome is for people with eating disorders. Now, it's not something that occurs exclusively in eating disorders. Starvation syndrome can happen pretty much to anybody at any kind of age, any gender, any body size, any body mass, but essentially it's the starvation syndrome is a collection of psychological and physiological effects of prolonged dietary restriction, and the effects of starvation are commonly kind of seen in people with eating disorders, or people who might otherwise be malnourished, and they are, you know, starvation syndrome is reversible. It is something that can be treated. So even so, someone, you know, a person with an eating disorder can be in starvation syndrome, and that will definitely impact on their ability. This is what I was talking about before. When, you know, when they get to that stage where they're medically compromised, they often are in starvation syndrome, and so they don't have the capacity to make the changes, or even to decide what their treatment needs to be from the next step. We've got on the next slide just the symptoms, or the symptoms and signs of starvation syndrome. So if you notice a patient who, you know, quite recently has lost a fair bit of weight, or is coming across as more kind of preoccupied with food and shape without losing weight, they complain about, you know, concentration issues, they complain about, you know, poor low mood, they complain about they're more anxious, they're more kind of irritable with people, they might be able to have a little sneaky joke with you, but they're no longer able to do that. They're usually, you know, they would, I guess there would be things I think about whether this person is struggling with starvation syndrome, because it is actually quite a different mindset when you're in starvation. When you come out of it, you can see that kind of the difference, the relief, the burden that kind of starvation can place on you is actually quite significant. We didn't make up starvation syndrome, but we should be very clear about saying that this actually comes from the Minnesota starvation study. I won't go into the details, but basically all the kind of symptoms and signs we list here, so these are kind of more the, you know, the psychological kind of aspect of that. They're from this kind of experiment done by and written up by Ansel Keys in the 1940s. It kind of goes into quite a fair amount of detail if you want to read the actual study, but basically we also will provide the link to at the end of the webinar about where you can access patient information sheet you can give to patients to explain what you think is happening for them. Okay, so you might ask, okay, well, what do you do? I've recognized this person is in starvation. I've recognized that they may have symptoms of an eating disorder. They've, you know, maybe had some physiological or psychological changes. You know, what should I do next? Well, a combination of things. But I thought this is an incredible slide that we should put up. So these are the medical complications of an eating disorder, or potential medical complications of an eating disorder. And, you know, on the left, you can see cardiac decompensation. So, you know, their postural tachycardia becomes really bad. Their blood pressure gets worse. They might have neutropenia because their bone marrow isn't working anymore because there isn't enough energy to spare for the bone marrow. Their liver is going off because, again, they're starved. They're not menstruating. They may complain a lot about constipation. They're depressed, they're anxious. They might even become suicidal. They're really incredibly worried about weight gain and tell you, I can't, you can't, I don't want to put weight on. Or, you know, they come and their blood sugar's kind of through the floor. What do you do? Well, treatment, the good thing is the treatment is very simple. It's nutrition. So it's about nutrition, getting kind of the brain refed in many ways so that we can reverse the syndrome of starvation and reverse some of the complications as well. I don't know whether I can stress that enough.
I suppose the difficulty, of course, though, is that the nature of the illness means that for most people with a restrictive eating disorder, the ability to actually then get the nutrition on board is the issue. And this is where that cycle starts to potentially kick in if they're not able to get the nutrition back on board very quickly, and perhaps change some of those pathways that have become so entrenched. That's where the circle can unfortunately start. So it's about us explaining to people that nutrition is their medicine, and that this is what we recommend. And of course, then it becomes the difficulty of how do they access that, and how do they actually then how are they able to actually take the nutrition in, because the nature of the illness will say that becomes the problem. And that is the problem, isn't it? That they can't get the nutrition in. And so that's where hopefully we can then start motivating them to access treatment, that families may, loved ones may be able to support them to be able to get enough nutrition on board to perhaps reverse things. But really it's about being able to change and challenge those pathways through therapy, hopefully.
But also it comes back to that table that we're showing up before.
Yes.
If they've met criteria on those tables, usually, like we said, by that stage, it really is about giving them the intensive nutritional support they need. And that, that with the nature of the illness cannot happen in the community anymore. It is something that is best kind of addressed in hospital by that stage, because as you can see, there's, if you refer to our previous slide about kind of the signs of an eating disorder, the one with the standing person, I'm trying to think of the figure, that kind of tells you why it's so important that they're in hospital. I realize I've jumped over a little bit about kind of why particularly I would mention cardiac and neurological concerns, but if you go back to that, we do kind of have that in quite helpful details in there. So there's some specific domains about eating disorders that we need to be aware of. By that, I mean that there's particular people with other comorbidities or with kind of particular eating disorder manifestations that we need to think about, because that's often what we come across actually a fair bit in our care of people with eating disorders. So type 1 diabetes, I won't lie, I don't know whether I should say this, but they definitely are someone with type 1 diabetes and eating disorder definitely scares me, because I am, and I'm sure you guys are aware of the potential risks that this person has, particularly if insulin omission is the way they deal with the eating disorder and the way they manage their shape and weight, or even if binging also forms part of that. That's also quite concerning, as you can imagine as well. The struggles that we often hear, and I'll preface that by saying I genuinely at times kind of do my little internal panic and go, what do I do? There's so many things I need to think about, but I always come back to what an eating disorder is. So the next kind of couple of things are about what we think is helpful with people dealing, kind of supporting people with eating disorders in the primary health space. So if they struggle with making sure they have their regular insulin and they often go into DKAs, we talk a lot about kind of harm minimization and kind of reducing the risk for them. Things like, is it better if they cannot use their short-acting insulin? Is it better that they consider they at least stay on their long-acting to reduce the risk of going into a DKA? If they restart the insulin, or even if they add, short-acting on top of their regular long-acting, being that they would be very aware of the insulin edema and kind of what that often can then trigger in someone with an eating disorder is literally the weight and shape concerns manifest for them in the form of, well, I've now used insulin, look at what's happened to my weight and shape. and being able to kind of work through that with the person. There's definite requirements of looking after type 1 diabetes that are quite difficult with someone with an eating disorder. So, you know, you have to carb count, you have to have particular rules. There's things you have to follow that in managing your diabetes that are very triggering for people with eating disorders to think about. But I will say though, at the end of the day, all these different things, all the kind of worries they have, that why they want the use of insulin, why they might have insulin demon, why they might have to carb count, they when you kind of work with them, when you drill down to the gist, it is about the eating disorder. So all these things, it is kind of treatable. It is basically, this is why we've got treatment is as per normal up there, because you can actually treat that, but it requires the person being ready and able to kind of address the eating disorder at the same time as kind of being kind of honest and truthful about what they're doing with their insulin. So in saying that, we then always say part of looking after someone with a type 1 diabetes diagnosis and eating disorder is that regular medical monitoring is a must, because we've mentioned some of the risks previously, and we know that, you know, the chances of someone with type 1 diabetes with an eating disorder is probably exponentially kind of worse in terms of what can potentially go wrong, electrolytes and fluid and everything else, and not even talking about sugars, and just kind of the general things that can go wrong. Now, child and youth space.
Yes, so the child and youth space, we're not actually a child and youth service. So this is some information we've got from our child and youth colleagues. And I suppose the big thing about eating disorders is that, you know, we know that the average age of onset for anorexia nervosa and bulimia nervosa, it occurs during adolescence. If they don't develop an actual eating disorder at that stage, what we find in our experience within the adult service, though, is that they've usually had disordered eating in the adolescent. They've developed the eating disordered eating in that adolescent space, and then it goes on to become full-blown eating disorder as an adult. Our KIMS team tell us that, you know, 80 to 90% of the people that get referred to them have actually got anorexia nervosa. And sorry, with an eating disorder, yes. And I suppose the big thing is, if it's not identified and treated early, then the illness may sort of do the transdiagnostic sort of course and evolve into a combined type at a later stage. They very much identified that for their cohort eating disorders, and we've recognised this certainly in the adult space as well, that they're often a coping mechanism, because they often, the young person is feeling very out of control with what's happening in their life, and they feel that the only thing they have control of is their body, and it's that weight and shape.
If we go back to our original life jacket metaphor, the way they kind of control is through, or the way they survive the stormy seas of their life situation is through that life jacket. And unfortunately, the life jacket happens to be an eating disorder.
I suppose one of the biggest things we find that certainly our colleagues have told us is that in the child and youth space, often people can mistake the early onset as a bit of it'll be something, a phase, that it'll be something that they'll grow out of, and we can just do a bit of a wait and see. From their perspective, they're saying, please, the longer the delay, unfortunately, the greater impact it's going to have on the young person. And so please, it's really important that we jump in as soon as we can. What's interesting is that there is an increasing amount of males presenting in that child and youth space. Not everybody is quite sure why. We just know that it's happening. There's not really the research out yet to sort of try and make head and tail of that. What they have told us is that unlike adults, malnutrition is not as well understood in the adolescent population. And once again, it's that if there is any slight suspicion, then it's important to refer as early as possible. And I'm sure you're all very much aware of that.
I would just like to pick up a point that an eating disorder is not a female disease. It happens, maybe not exactly equal, but it happens quite close to, I think it was 63.
2/3 to a third.
Yeah, 2/3 to a third. So please, just because they are male doesn't mean that they don't have an eating disorder. The other thing about the child and youth space is that when they have the difference between kind of adult and child treatment of eating disorders is that you always want to intervene, and you want to intervene as early as we can in a child and youth space, as we've talked about just now, but also that there's particular gold standard treatment that the family should be involved in, which is the family-based therapy, FBT. CBTE, which is often the kind of gold standard in adult space, is actually ineffective for young people, often due to kind of immature brain development, because it is a very different kind of way of dealing. They're very different ways of dealing with eating disorders. So please, if you think that they have, our child and youth colleagues are very happy to receive referrals for people with eating disorders.
So just before we move on, the only other thing perhaps is the importance of understanding that sometimes the child and youth space people are presenting with anxiety and depression. So what we find is that often the anxiety and depression is actually can be an effect of the starvation or the restriction that's going on for someone, and their whole anxiety and depression being exacerbated by the restrictive eating disorder or the whole development of an actual eating disorder. So it might be just something worth exploring if someone is presenting into your practice who is coming in with an increase in anxiety and or a potential depression presentation. It's probably worth doing the SCOFF questionnaire and SCOFF screen and just checking that there isn't some eating issues underneath.
We'll check with the parents and see what their intake is like, or caregivers, I guess, kind of assume. Okay, now the other thing that I'm also equally passionate about, so eating disorder in larger bodies. It makes sense, but there's been kind of this historical image of eating disorders as anorexia nervosa. So in fact, that only represents about 3% of people with eating disorders. We talked about binge eating before at the very start as a diagnosis. That actually is probably something like 68% of people with eating disorders actually have binge eating disorders. So as you can see, lots of people may exist in larger bodies who have eating disorders, but they may not get recognized as an eating disorder because it doesn't fit the typical image or preconceived idea of what an eating disorder looks like. The other struggle that I often kind of hear is that often people, because they are larger bodied, people again have this conception that, oh well, they're not sick enough, and they may have, inverted commas, reserves, so they're unlikely to be medically unwell. But we are basically here saying that eating disorders, regardless of their body size, their BMI, body mass index, once they have an eating disorder, particularly if they're starting to restrict, it doesn't matter what their body size is, their medical risk is the same across the board. There's definitely stigma. There's definitely kind of inadvertent reinforcement of kind of weight loss and what that might do for their health status. That can happen at times. They struggle often for themselves, like as I said before, to recognize that they have an eating disorder. And what often might, so in terms of kind of treatment initiatives for people with larger bodies, to help them with their blood pressure, or to help them with their sugar control, say if they have type 2 diabetes, or to help them with cholesterol, things that we normally would think about, what we've been taught in med school to say, if you think about losing a little bit of weight, that might be helpful for that. Often that can be incredibly difficult for people in larger bodies, because then that kind of reinforces the idea for them that maybe, you know, it isn't that if this is what my doctors are saying, then maybe the other stuff that I'm concerned about isn't kind of it's going to be solved by my weight loss, rather than recognizing that there's an eating disorder also kind of in the playing field. Okay, so now that we talked about all the other stuff, we'll come to treatment options. I always think that to kind of help someone with an eating disorder, your number one most important thing is making sure that they're medically safe, that they're medically monitored. And this is why GPs and GP practices are so important in people with eating disorders care, because often they're not ready to engage in the psychological treatment available, but they you know, their risk doesn't change and their need doesn't change. So I've talked about before, where in child and adolescent it's family-based therapy, FBT. In adults, there's definitely a number of different evidence-based psychological therapies for people with eating disorders. I guess in terms of kind of what they have, sorry, I'm stuttering a little bit there. They range from you know, cognitive behavior therapy enhanced to specialist supportive clinical management of anorexia nervosa, to Maudsley's adult anorexia nervosa, so Maudsley anorexia nervosa treatment for adults. So there's actually quite a broad range, but in terms of efficacy and effectiveness, I always think that it's really, really important that if someone has an eating disorder and seeking help, that when you make the referral for them to see a psychologist, please kind of ensure that the psychologist is number one, an eating disorder specialist, but also that they actually engage in providing evidence-based psychological therapy, because there's nothing more disheartening than going to seeing someone and then feeling that there hasn't been any changes, and thinking that you've made all the effort of making a change to deal with your eating disorder, but not necessarily getting the gold standard treatment that would be otherwise effective and useful. So we're almost to the end. We thought that this slide is quite important because it is quite difficult kind of looking after people with eating disorders, particularly in the primary health space, when often they may not be willing to go and see a psychologist or dietitian, then you're kind of the only person left kind of holding on to them, trying to make sure they're alive and safe and everything. So they're some of the things I think about, even in my own practice, about looking after people with an eating disorder. So for them, your contract with them, the way I think about kind of interacting with them is that there's non-negotiables of making sure that their medical and psychological safety are met. Then it's equally important that you're looking after yourself, and when you're interacting with the patient, you externalize eating disorder. So rather than naming them as the problem or naming, you know, that this person has this issue, it's about saying and being able to help them separate that the eating disorder is not the same as themselves, and the eating disorder thoughts are, again, not their own thoughts. There's some good resources we can point you guys to if you kind of want to kind of know a little bit more about that. I thought that equally important that in looking after people with eating disorders, I always engage in kind of peer support. So things like balance groups, or things like our psychiatrists, kind of peer review to make sure that, you know, you're able to kind of you know, have the sounding board, but also to make sure that you're also, like I said at the start, you know, looked after, because they really do kind of you know, they really do draw on your emotions. They really do kind of challenge your thinking quite a fair bit. The other really important point we thought is that it's really important to make sure that you, and it's kind of quite contradictory to our role as doctors and nurses and kind of health professionals, but it's not up to us to make them recover. We're there to walk alongside them, to help them, to provide them with access, to provide them with recommendation and advice when appropriate, but you cannot make them recover. That is not how you help someone with an eating disorder. And sorry to say this, but definitely be prepared for the long haul for some, particularly if we've missed the 2 to 3 year mark. That's definitely something to kind of think about. it's important that you hold firm to your boundaries to make sure that, coming back to, medical and psychological safety first, they may kind of plead and beg, I don't want to go into hospital, but there are some boundaries that you have to hold firm so that, because one day you'll be alive. But two, often what we hear from lived experience speakers is that once they've kind of gone through kind of their illness and are towards the side of recovery, they then talk about how important it is that someone is holding that line for them when they can't hold that line for themselves. In the same vein, be firm to be kind. Just because you're holding firm doesn't mean that you're being cruel or rude. You're literally trying to make sure they stay alive and save their lives. And because sometimes it is for the long haul, maintain the hope for them that they can recover. Because often they'll say to you, I don't think I can see anything outside of what my eating disorder. But we know that people do recover. And consistently, we've had people in our service who've had 40 years of eating disorders and they have recovered. And don't forget to involve the family and loved ones, particularly if it's appropriate, in the person's care. There's a whole, sorry, I almost swore. There's a lot of other things I do think about, but they're probably the most important ones. And we've just got a quote that I think is so kind of interesting and kind of speaks to a little bit about what we were just talking about. So I'm not allowed to choose to eat, but if I have to surrender to eating, then the eating disorder doesn't punish me as much. So by you holding firm and saying you have to do certain things, you're kind of allowing, so you, even though you feel like you're taking the choice away, you're actually helping them, as you can see by that quote. So key messages. Okay, I always belabor this point. Thiamine, vitamin B1, 100 milligrams, 3 times a day. Please, if nothing else, if you know they're not eating, if you know they're malnourished, and if you know they may or may not be thinking about getting back to eating, or they may have an inconsistent pattern of intake, can you please make sure that they have thiamine? Because we don't want the kind of progression onto Wernicke's or Korsakoff's. That happens in people with eating disorders. I have seen that happen. It's an incredibly difficult thing to witness. Multivitamins, self-explanatory. Medical monitoring, we've just kind of spent, I feel like, a slide belaboring that, so I won't go into that. Evidence-based therapy, incredibly important. Please make sure if they're going to go engage with a psychologist, that they are engaged in evidence-based therapy and not therapy that might actually be also useful, but not necessarily targeting the eating disorder. Externalize the eating disorder from the person. They are not their illness. They're not their thoughts. They're not their eating disorder thoughts. An eating disorder is not a choice. I don't think I can stress that enough. An eating disorder is never a choice on the person's part. I kind of give this example. So when you're born, the first thing you do is you breathe. The second thing you do is you suckle. To go against your instincts that something is wrong. It's not a choice that they make, and that for some, it's an eating disorder is a chronic illness that lasts an average of 7 years. So it's something that there is a potential for long haul, and you will be the most important person in their life from that point onwards. So last slide, we thought we'd just pop up some of the wonderful resources that are available that you can Google. As you know, the Butterfly Foundation, the Queensland Eating Disorder Service is where the statewide guidelines are. NEDC has some amazing kind of patient information sheets that you can give to people, as does Centre for Clinical Intervention. Centre for Clinical Intervention actually has a particular patient information sheet on starvation syndrome that I really, really absolutely love. And then there's the Academy the Australian New Zealand Academy for Eating Disorders. And then there's also the incredible Eating Disorder Queensland, who does amazing work with kind of supporting people through lived experience with eating disorders. You can see there's definitely the Butterfly Helpline as well that the individual and their family and friends can call. Okay, now I can see a flash. Oh, I can't make the mouse work. Just gonna see if there's any particular questions. Okay, we've got 2 minutes for questions.
Hi, hi, it's Jodie from PHN, just reading the questions out for our lovely presenters. We've got a question from Stephanie. Can I please confirm if it is recommended to withhold or hide the current weight from the patient during their weekly check, and why this is thought to be necessary?
Okay. I have two thoughts about that. So if they're asking not to see their weight in your medical monitoring of the patient, that's absolutely fine, because often that's quite triggering for the patient with an eating disorder to see the weight, because they get incredibly preoccupied with the numbers. So even like the 0.1 or 0.2 difference, which in the rest of us we would just say, oh, we haven't voided our bowels or bladder, for them that is actually they've gained weight or they've put fat on. So that's why we often say it's okay for them to have a inverted commas blind weight. It's a little bit different when they go into therapy though. So in therapy often then you have to know about your weight, but that's a different kind of thing entirely.
They still need to be weighed though. That's the thing. They don't have to see what the weight is, but they still need to be weighed, because we know we need to keep them safe. That's basically what it comes down to.
Well, that's the only question so far. Has anyone else got any more questions? Well, we've got Amy and Jocelyn here. Just give it a couple of seconds. Looks like everyone's fairly shy.
That's okay. All good.
All good, guys.
Thank you very much for giving us this opportunity, and please don't ever hesitate to call us. That's what we're here for. We're very happy to help and support. We absolutely acknowledge the great work you guys are all doing out there, because I think sometimes you're sitting in a really challenging space, and so please don't ever hesitate to call us to see if we can be of support. And have a great day.
Have a great day, guys.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.